Scenario-based, critical decision case studies. It's going to be open. We're going to do it as a group. Trying to keep it as controlled as possible because you guys get out of control really easily. I've already noticed. So we'll go through it. I'll read it and we'll just kind of discuss it and analyze it. And once we're done, we should feel pretty comfortable about everything we learned today. Sorry, I didn't realize this slide was here.
These are all naturally going to be like military things because the NAEMT did it, but it was a new thing they introduced last year that's mandatory for the course. So I'm gonna throw it in today and get rid of everything. No more PowerPoints for the rest of the course.
Heck yeah, I'm down with that. Okay, disclaimer. The opinions or assertions contained herein are the private views of the authors and not to be construed as official or as reflecting the views of the Department of the Army, Air Force, Navy, or the Department of Defense. They could have just said Department of Defense, right? There are no conflict of interest disclosures. All right, now we got that all out of the way. Learning objective, apply your knowledge of TCCC to selected critical decision case studies in TCCC. Okay, the biggest challenges in TCCC, knowing when to use the interventions taught in TCCC based on suggestion by Colonel Bob Mabry. TCCC critical decision case studies will help to illustrate which interventions to perform for casualties with life-threatening conditions. Okay, here we go. Case study number 1, bleeding case study. The setting. A unit is on a dismounted mission in Afghanistan. Dismounted IED attack. The unit has no junctional tourniquets. There is no effective incoming fire at the moment. Okay. The casualty. Well, let's talk about that real quick. Dismounted IED attack. So an IED is an improvised explosive device. Okay. Explosion. No junctional tourniquets. No effective incoming fire. Those are the key points there. IEDs usually equal amputations, just for your little essay. Okay, casualty, high amputation right leg. Below the knee amputation left leg. Ongoing massive hemorrhage from his right leg amputations, bleeding profusely. Too proximal to be controlled by a tourniquet. So that means it's high up in that junctional area. Okay. Question, what is the next action you should take? 1, combat gauze applied with at least 3 minutes of direct pressure at the bleeding site. 2, start an IV. 3, construct a pressure dressing over the bleeding site. 4, apply direct pressure over the femoral artery at the level of the inguinal ligament. 4. Consensus, we all think direct pressure should be the first thing that we do to stop that profuse bleeding. 4, I think I would agree with that. 4 is good. And then the next step maybe would be some hemostatic gauze, but let's hear it. Correct answer. 1. Hey, fair enough, we're learning, right? Even me. Combat gauze applied with at least 3 minutes of direct pressure at the bleeding site. Okay, in this casualty with uncontrolled junctional bleeding in the right upper thigh, since the unit has no junctional tourniquets and since the bleeding site is too proximal on the leg to be controlled with a limb tourniquet, the best option is direct pressure with combat gauze. Pressure dressings and pressure applied to so-called pressure points at vascular sites proximal to the bleeding have not been proven to be effective. Okay, so fair enough. They got us on that one in the sense that they're saying combat gauze with direct pressure, that was the key word, direct pressure over the wound is going to be the answer. Do we understand why that's the case on that one?
Better answers.
The better answer, right?
Is that one of the situations where, like, your friend that had his legs blown off and they put the rigger's belt around him in the spare barrel? I mean, like, figure maybe some sort of a tourniquet that you can do on the center of the body?
Sure. So thinking outside of the box, we could fashion a junctional tourniquet since we don't have one, right?
Yeah, I know it said you don't have one.
Right. There's not an option. We could have fashioned one, like you said, and we can do some other things that we're going to teach you as well. But for the case of the TCCC committee, the better answer on this one is direct pressure with a gauze impregnated with hemostatic agent or quick clot, right?
This would be first anyways, even if you were to fashion something that provided mechanical pressure.
Right.
So this would still be the first thing
While
you
you're
do.
doing something else.
Yeah, so this is definitely the first thing you would do, and then you might fashion one of those things that these guys will show you that will provide more mechanical pressure afterwards.
Okay.
Yeah.
So we understand where 4 could be correct, but we understand that the best answer is this one. Cool. Okay, cool. The next scenario, the setting. A squad of Marines, heck yeah, is engaged in a small arms battle with hostile forces. RPG, which is a rocket-propelled grenade, blast near one of the unit members. Casualty lying on his right side. There's no effective incoming fire at the moment, so it's just one isolated RPG blast, which is not uncommon. They like to do that. The casualty is moving around and awake, but his movements are not purposeful and he is not responding to questions. Face and neck wounds, not airway, are present. Several teeth are missing and there are lip and cheek lacerations. There is ongoing severe bleeding from the neck wound. No other major bleeding sites are immediately noted. He is voicing significant pain. Okay. Question, what is the next action you should take? Perform a crike, start an IV, apply combat gauze with sustained direct pressure at the bleeding site on the neck, administer oral transmucosal fentanyl citrate to fentanyl lollipop, in other words, treat the casualty's pain. Three. Apply combat gauze with sustained direct pressure at the bleeding site on the neck. Why would you say that one?
He's not having any airway issues.
Yes, it's just lacerations on, what's the severity of that?
Let's just, we'll,
Teeth are missing,
Cheek
lacerations to the
lacerations.
lip and cheek.
I'd go with 2, start an IV, if it's not describing a major bleed.
fair enough.
Ongoing severe bleeding
Said
at
it's
the neck.
severe bleeding.
Yeah.
Okay, why would we say severe bleeding though? Just the most basic thing that we've covered all day today. But
Marsh.
M, absolutely. Just remember that, because just like these scenarios are convoluted and there's a lot of details, just remember, in real life too, it's gonna be the same situation. This patient has so much wrong with him and I can see it all. Remember M, remember March, pause, and that will keep you on track, absolutely, right? So if we have bright red bleeding anywhere, that's always gonna supersede everything besides security, right? That's the only thing that can change what you're gonna do right then, is if you're not safe anymore, right? M, I agree with you. 3, let's see if we all get embarrassed again. Applying gauze to stop that bleeding. Wow, we made it this time, good job. Apply combat gauze with sustained direct pressure because M supersedes all, we win. This casualty has massive hemorrhage from a neck wound. Tourniquets are obviously not usable, so sustained direct pressure with combat gauze is the best hemostatic option available. Also, opioid medications such as fentanyl lollipops should not be used in casualties in or at risk for shock, which this casualty definitely is. Real quick on this one, even if the patient did have respiratory distress, would you do anything different?
No.
No, because
Yeah,
M supersedes J.
yeah.
Absolutely, good. We just gotta keep it black and white on that one. That'll help us. Okay, cool. Next one, setting. A small unit is moving across an open area. It is night and there is zero visibility without night vision devices. The casualty has a gunshot wound in his left leg just above the knee. The unit is still taking effective incoming fire, so it's still dangerous. We got a casualty. What should we do? Casualty, there's severe bleeding on the thigh on a blood sweep. Visualization of the bleeding site is poor, and he's in extreme pain. I bet he is, he just got shot. What is the next action you should take? 1, apply a limb tourniquet high and tight on the left leg. 2, try to guess where the bleeding site is and apply a limb tourniquet just proximal to that. 3, administer fentanyl lollipop to the casualty. 4, administer ketamine to the casualty.
One and move.
You sure? Okay, 1. Let's make sure it's on the left leg.
Yeah, I was gonna say that.
Yeah, I'll give you a bone because I'm exploring this too. So it is wound to his left leg. Okay, bleeding is an issue. Severe bleeding on the thigh. Awesome. So we're gonna say A or 1. Apply a limb tourniquet high and tight on the left leg. That's our consensus. Yeah. I agree with you. Even though ketamine would make this funner. Apply a tourniquet high and tight to the left leg. We could have seen that one coming. For this casualty with potentially life-threatening bleeding from the gunshot wound to his leg, the most important aspect of care is to control the extremity bleeding. Since the bleeding site cannot be definitively located at this point in his care, the hemorrhage must be controlled by immediately applying a limb tourniquet as proximally as possible on the extremity. Treating the casualty's pain is important, but should be done after bleeding is controlled, once the unit is in the tactical field care phase, at which point should you be giving pain medication? In March, pause. E, absolutely, there we go. It sounded like a trick question, but it wasn't. Okay, good job. All right, number 4, setting. A U.S. military advisory team is assaulting a terrorist compound. Sounds like fun. They take small arms fire from a roof. One team member sustains a gunshot wound just below the left clavicle. Ugh, I hate that sound of that. The casualty is moved to cover for treatment. There is no effective incoming fire at the covered location. Okay, casualty. There's very heavy bleeding from the wound just below the left clavicle. Breathing is not labored. The wound is noted to have a deep wound tract. Efforts to control the bleeding with combat gauze are unsuccessful. I could have bet money on that one. All right, so let's see what we're gonna do. 1, construct a pressure dressing over the wound using standard gauze. 2, start an IV. 3, use a hemostat to reach into the wound and clamp the bleeding vessel. 4, apply X-stat into the wound tract.
3.
You guys know what X-stat is?
No.
So it's this syringe filled with these small little expanding gauzes. When you inject it into it, they all expand at a very quick rate as soon as they touch blood, which will fill the wound tract up and create very good pressure in traditional wounds that are kind of hard to compress. And they're not
Isn't that recently new? The Israelis made it?
Huh?
Isn't that just recently new?
It came out in the last few years. It really hasn't been a mainstream topic of discussion because it was very expensive and only the highest level, like tier 1 people even got it. So just food for thought on that one. What do you think we should do?
3.
Clavicle, uncompressible wound, probably hit that subclavian, the nightmare wound that I tell you about. So what are we gonna say? We got here 3 by somebody?
Same 3.
3,
Yeah.
so we're gonna make a movie out of this. 3, I like your style though. Where are we at? Is that it?
I would say 3.
Okay, so we got 3 and we got a 4. No IVs, no ketamine? No? Okay. No pressure dressings over the wound? 3 or 4? Okay, cool.
3 or 4.
We'll see, we got a 50-50 chance. 4, apply the X-stat into the wound tract. Tried to paint the picture for you, but we didn't really go over it, so we're learning about it right now, right? For uncontrolled bleeding from a wound with a deep wound tract, such as this casualty, X-stat is clearly the best of the listed options. Neither a limb tourniquet nor a junctional tourniquet is usable, and combat gauze has not been effective. When I had to treat 2 patients with this very exact wound, we didn't have it. So a hemostat and some fingers and a positive mental attitude was all I could get. I'm telling you. So I'm there with you, dude. Like if you don't have the $1,000 X-stat syringe, then putting some fingers in there and trying to get some pressure on that subclavian up against the clavicle or anything is your best bet option. But here we have that Gucci stuff, so we use it. Okay. Number 5, setting. A helicopter is disabled by small arms fire and crashes. 2 of the crew are dead. 1 crew member has a severed head, has severe head trauma, Freudian slip, has severe head trauma and is unconscious. She is being treated by another medic, You are treating the 4th member of the flight crew, the pilot. There is no effective incoming fire at this crash. Okay, let's look at the casualties. Casualty. The pilot is alert and complains of severe left hip pain. Breathing is unlabored with an O2 saturation of 96%. Blood sweep shows no external hemorrhage. You examine his pelvic region and find a large area of bruising over his left hip. There's marked tenderness to palpation, which means to touch when you touch it in that area. Okay, so we got a little picture painted. Helicopter crash, left hip pain, severe. Okay, sats are at 96, not too shabby yet. Casualty dashboard. Okay, so they're APU, we talked about that, alert to verbal, pain, or unresponsive. They're alert. Airway, it's patent, which means it's clear, it's working, right? Patient is talking well. That's a great indicator of whether they have an airways if they're talking to you. Breathing, respiratory rates 19 and unlabored, which is a little high, right? 19 breaths per minute. Radial pulse, present but weak. And then O2 saturation 97%. So what does this tell us?
More than likely there's internal bleeding.
Okay, I like your style, dude. What about this tells you that?
Well, he's got a little bit increased respiratory rate, like you were saying, not labored, but that weak radial pulse
So why
would show that it's just starting to compensate at that point, shunting a little bit.
Absolutely, compensation starting to occur, right? Okay, and then why would that radial pulse be weak?
Let's,
First one to go.
Yeah, we're losing that blood pressure, right? We're losing that blood pressure. Cool, I like your style. Let's see what options we got here. Administer fentanyl for pain. Apply a pelvic binding device for suspected pelvic fracture. Start an IV and administer 500 mLs of Hexten, or administer the combat wound medication pack. 3. Okay, so we're going to start an IV and administer 500 mLs of Hexten. All right, real quick, what I want to just suggest to you, right? We talked about pelvic injuries and the importance of putting some binding around it. Why do we talk about that? That's important that we stabilize it. I probably didn't explain it very well then.
Because there's arteries that go through there and stuff, and you could.
You can bleed out in the interstitial space.
Okay, so there's potential bleeding is the cause, right?
It's as close as you can get to like pressure in there.
Sure. So what we're seeing here, we're trending that they're compensating. They seem to be in some type of hemorrhagic shock, like they're compensating, right? And they're bleeding, right? Potentially from the pelvis. By binding the pelvis, we could potentially tamp off that bleeding and control it, right? Just by approximating those bones that are bleeding. So this is food for thought. You make whatever decision. I don't know what the answer is. I'm taking this for the first time with you. But just going off the March algorithm,
Yeah.
where would bleeding controllability go versus pain control? Or sorry, even Hexton, adding IV resuscitation, where would it be?
First.
Okay, so did that change your decision?
Two.
If you're wrong, don't blame me. I read the disclaimer in the beginning, remember?
I would-
So where are we going with this one?
I'd probably say 2.
2?
Yeah.
2, anyone still want to push Hexton at this point?
I feel like Hexton wouldn't be like a bad option, but maybe first you would want to do something. Go through
You
it.
gotta
Bleeding? Okay, cool. I think we're going in the right direction. Let's see what happens. Boom. Okay, so binding that pelvis, trying to close that off to stop that bleeding. M supersedes all. The diagnosis of immediate concern here is a suspected pelvic fracture. So a pelvic binding device should be applied immediately. This could be a t-shirt, this could be a blanket, this could be many things that will show you how to fashion. Doesn't have to be something Gucci with Sam written on it. Okay, pelvic fractures may be associated with non-compressible bleeding. This casualty has a weak radial pulse and may be going into hemorrhagic shock. Bingo. He may need fluid resuscitation shortly, but the pelvic binding device should be applied first. Fentanyl lollipop should not be used in this casualty. Why?
Lower
blood pressure.
Yep, that's what opioids do, right? They don't make weak pulse pressures better. They make them worse. Absolutely. And we don't want that. That's how you die. Okay, study 6, the setting. An Army infantry squad is on foot patrol in Iraq. That's hot. A dismounted IED detonates, causing multiple casualties. There's no effective incoming fire at this point. So we're walking, we hit an IED, there's an explosion, many people are hurt. Let's see what we got.
Can I ask a quick question?
Yes, sir.
I'm sorry. So there are different types of IDs, so what is a dismount?
That's why I paused, because the way it's worded is confusing. But I think what they're trying to say is that they were walking when they hit the IED, not they were rolling in their vehicles when they hit the
Oh,
IED.
I see.
So it's just it's still an explosion, but they're painting the picture for you that they weren't inside the Humvee, they were walking. Yep. That's why I paused right there. I'm like, what did I just say? Okay, next one. Casualties. The casualty you are treating has bilateral, which means both sides, lower extremity amputations, chopped off their legs. Both are very high up on their legs. There is severe bleeding from both amputation sites. Limb tourniquets are judged unlikely to be successful, okay? And then no other life-threatening injuries are noted. I say, how are you gonna know if tourniquet's gonna work if you don't try it? Like, what do I know? What next action should we take? Administer ketamine since the casualty is at risk of going into shock. Start an IV administer TXA, okay? Construct pressure dressings using standard gauze for both amputation sites. Or 4, apply direct pressure with combat gauze until the unit's SAM junctional tourniquet is ready to be applied.
4.
It's just like the first one.
Yeah, it has a nice ring to it. I agree. Yeah, I agree. I think that's a good option there for this guy. So let's go with 4. We sound unanimous. Boom, nailed it. Cool. The correct next action is to apply direct pressure with combat gauze until a junctional tourniquet is ready to apply. This action may prevent the casualty from going into shock. Because bright red blood in the body is better than on the ground. Okay. An IV of tranexamic acid and ketamine are all good follow-on actions in this casualty, but the first priority is to control massive hemorrhage, which this casualty currently has. He's got no legs. Okay. What's going on? We're back to study 1. Circulation. Okay, it's a different section now. We're thinking circulation. Setting. A small unit is moving outside of a village. There's a single shot from somewhere in the village. Classic. No other hostile fire. The casualty. Single gunshot wound to the abdomen. The casualty is alert and in moderate pain. There's no life-threatening external hemorrhage. there's there's a normal radial pulse, okay? We should all be thinking about a gunshot wound to the stomach. This could go many places. Dashboard, APU, alert. Airway, it's working. Breathing, respiratory rate of 18 and it's unlabored. Radial pulse is strong. O2 saturation is 97%. Anything remarkable about that?
No.
Sounds pretty normal. What if we saw that the pulse was rapid and that the breathing was rapid?
Be nice and shock.
In shock?
Yeah, I was working on it as far as blood loss or whatever, I think, in the abdomen.
Okay, I like your style, but I just want to paint this picture too, just because we're doing this. He just got shot in the stomach. You know what I'm saying? Like immediate vitals may be skewed by the fact that you were just running when you got hit, or oh god, I just got shot. You know, so just remember, not everything is a trend, or not everything should send you off the rails. Maybe it's just normal for that moment, okay? But I don't want to throw any monkey wrenches in your stuff, so I don't see anything remarkable here as of yet, right? Respiration rate maybe is a little high, but you just got shot in the belly. Okay, so let's see what our options are. Start an IV line and administer TXA immediately. Start an IV and administer a unit of freeze-dried plasma. We got all the Gucci stuff today. Administer 50 milligrams of ketamine IM. I'd like to start there. Administer an 800 UG, whatever that means.
Microgram.
Yeah, that's written in New Zealand talk. Fentanyl lost me. Okay, which one do we want?
One.
One? Okay, 111. Sounds pretty unanimous. Anybody else? No ketamine? All right,
It's 1.1.
1.1.
Ketamine's 1.1. We'll do one, and we'll do ketamine.
Oh man, Rocky, we'll party after this. Once we graduate, all right. Okay, cool. 1, start an IV and administer TXA immediately, because we all know that those uncompressible hemorrhages in the box deserve TXA, absolutely. This casualty may have a life-threatening intra-abdominal hemorrhage. The next action should be to immediately start an IV and infuse 1 gram of TXA over 10 minutes. You guys nailed it. 2, setting. Small unit is patrolling outside of a village. There's a single shot from somewhere in the village. No other hostile fire. What's up?
That seems strangely familiar.
Yeah, it's
So
like,
you should stop going by that village. I mean, to tell you the truth, in Iraq anyways, traveled around over there for a couple of years. If there's a single shot coming out of a village, it's usually an ND. And someone usually just blew somebody's head off on accident, or their own foot or something. Every time we heard those single shots, it was usually a mistake that either a security guard made in a plant or a factory, or just somebody had playing with a gun.
yeah, or every time we would go out of the wire, we'd get off a helicopter into a compound, we'd shoot a chicken or a dog, and you know, make sure our BZO's good. You don't know unless you do it. So we'd always like shoot a chicken, and the Afghans are with us, and we'd say test fire, and just keep going, right? One day I come out of the camp, and these Afghans are out there messing with their gun, and he goes, and he shoots the ground, and they're all like, oh shit! And then he looks at me, and goes, test fire! I just looked at him, I'm like, yeah, I ain't mad, dog. Just put that gun away. I was like, that's awesome. Okay, cool. So classic village shooting at you. Casualty, single gunshot wound to the abdomen. Casualty was alert initially, but is now becoming confused. Radial pulse is weak. You have already started an IV and administered a gram of TXA. You're the best medic ever. That's good. Okay, cool. Just take a little thing here. Let's see what we got. APU, alert but confused. Airway, patent, it's working. Breathing, respiratory rate 20 and unlabored. Radial pulse, present but rapid and weak. Okay. And then O2 saturation is 96%. Okay, gunshot wound to the abdomen. Pulse is weak. Already had TXA on board. Anything remarkable about this right here?
Rapid and weak, so anything that's.
Okay, yeah, that pulse is definitely telling us a little story. Looks like the breathing's coming up a little bit there. Looks like our O2 is going down just a bit, right? What is probably the most important indicator of his condition here?
Confused.
Yeah, his mental status is not looking good. So when oxygen stops making it to the brain effectively, you start acting weird and then we lose consciousness, right? Cool. So at least we've identified these things. What should we do next? Administer another gram of TXA, infuse 500 mLs of Hextin, administer a unit of fresh whole blood as per unit protocol. Dang, I want to roll with these guys. Administer 1 gram of ertapenem to prevent infection.
3.
We got 1 for 3.
3.
3?
3.
3? 3? Okay. 1 with 3. Alright,
If you got whole blood sitting around.
Yeah.
yeah. Why not use it, right? Administer a unit of fresh whole blood. You guys are awesome. We didn't even talk about that. Alright, the casualty has gone into shock from intra-abdominal hemorrhage. The best resuscitation fluid for hemorrhagic shock is whole blood all day, every day. And giving a unit of that should be the next action taken. I agree. I agree. Maybe, hopefully there's units of whole blood in your stop the bleed kit. Okay. An Army infantry squad is on foot patrol in Iraq. A dismounted IED detonates. There are multiple casualties. There is no effective incoming fire at the moment. So you can't be walking around in Iraq. Your casualty has bilateral lower extremity amputations. There was previously severe bleeding from the amputation sites previously. Limb tourniquets were quickly applied to both legs and are effective. The casualty is alert and in significant pain. His radial pulse is normal. The casualty also has multiple penetrating wounds of the abdomen and pelvis. Okay, 2 amputations, bleeding's controlled, penetrating trauma to the abdomen and pelvis. Dashboard, APU, he's alert, he's talking to you, he's in pain. Airway pain, he's telling you he's in pain. Breathing, respiratory rate 16 and unlabored. Radial pulse is strong, O2 sats is 95. Let's see what we got. Start an IV and administer 1 gram of TXA. Start an IV and administer 500 mLs of Hexten, since there are no blood products available on this operation. Administer 50 milligrams of ketamine IM. Try to convert both tourniquets to the other modes of hemorrhage control. I know which one's not the one. What do you guys think?
Just because of abdomen, I'd say TXA, but.
Yeah.
Okay, I mean, because that's potentially bleeding, right?
Yeah,
bleeding
although there's
support.
no other signs on his dashboard that he's having internal bleeds.
Okay, fair enough. What else we got? Oh, what are we doing? Test fire. What do I got? 1? Okay, cool, I like that too. Let's see what we got. Cool, administer that TXA. Why? Because potential internal bleeding, M supersedes all. We'll get to his pain down and pause. Yep, this casualty does need battlefield analgesia, but the most important aspect of care right now is to start an IV and administer 1 gram of TXA. He's at risk of non-compressible hemorrhage due to his penetrating abdominal and pelvic wounds. He does not require fluid resuscitation at this time. Good. Good job. Okay, next. Airway. We're in the airway section now. An IED detonates underneath the vehicle in a mounted convoy. The vehicle is turned over by the blast. The casualty is unconscious. She was not wearing a seatbelt. Her helmet is dented. Dented, are we in World War II? There is no effective incoming fire at the moment. Alright, I've never seen dented Kevlar. Let's see. Okay, cool. The casualty, blood and bruising over the right parietal area. That's this side of the head, right here. No facial injuries noted. No other injuries noted. The unconscious casualty has been removed from the vehicle and is in the supine position. Chin lift maneuver accomplished. All right. Let's see what we should do. APU, she's unconscious. Airway, no injuries noted. Okay, breathing, respiratory rate is 12, but shallow. Shallow is a key thing there, right? Radial pulse is normal. O2 sats, oh, that is not good. 70%. So based on what we know, right? Explosion, obviously her head hit hard enough to dent her Kevlar. She has obvious bruising to the side of her skull. She has low O2 saturations and she's unconscious. Her breathing is shallow. What can we deduce from all of this? Hemothorax? Okay, that's one.
TBI.
Okay, TBI, we're getting close. What about the TBI would indicate these types of increased cranial pressure? I think we're almost there. So, okay, increased intracranial pressure secondary to head trauma because of her smashing her head on top of the Humvee, right? Cool, let's see what we're gonna do about it. Kriker? I don't know, maybe, right? Place the casualty in a sit-up and lean forward position, tripod position. Okay, start an IV, insert a nasopharyngeal airway. Huh. They really hooked us up on these options, huh? So, Head trauma, facial's intact, no other injuries, unconscious. She's in the supine position, so she's laying on her back. Chin lift maneuver accomplished, so they were able to get her head back. Blood and bruising over the right parietal area of her head. She's breathing, shallow. Which one do you think we got?
NPA?
Which one?
4.
4?
4?
Yeah, I got 4.
4? Okay, consensus says 4. Let's see what we got. Dang, nailed it. All right, good job.
So-
Insert a nasal pharyngeal. What's up?
Sorry. Would you be worried about a C-spine injury with that mechanism of injury and worry about doing a head tilt?
Yeah, I would. I definitely would.
Yeah, I would
But
get
the
shocked
chances
when I
of it
see
being a
that.
compression fracture is probably great. But, what are you gonna do? If you don't get them in airway, what's gonna happen? Yeah, they can die, so.
Practical scenarios, they sort of put away the C-spine issue.
Yeah.
Completely.
Kind of gotta do whatever you can to get them breathing, so at least they can survive paralyzed. This casualty may have an airway obstruction. The low pulse oximetry reading indicates a critical level of hypoxia. This casualty needs her airway open immediately. There are no facial injuries noted, so cricothyroidotomy should not be attempted because her face doesn't look like a duck, right? Until less invasive measures have failed. The casualty should not be supported in a sitting position because of this potential for spinal cord injury. There we go, Rocky, you're all over it. Inserting a nasopharyngeal airway is the best option of the choices shown. Cool, but you're in the right path, right? Setting, the small unit is on foot patrol. There is incoming fire from 2 hostiles. A hostile threat is quickly eliminated by the unit's grenade launcher. One of your unit members sustains a gunshot wound to the lower face. There is no further effective incoming fire. Okay, we got facial trauma. Casualties awake. There are facial wounds to the lower jaw and teeth. There is blood in the mouth. The casualty has noisy, rapid breathing. While in the supine position, it sounds like a duck quacking. He is struggling to breathe. Have poo, alert. Airway, facial injuries. Okay, cool. Breathing, respiratory rate 22 and quacky. Radial pulse, strong. O2 saturation 75. Riddle me this. Let's see what we're gonna do. What is the next action you should take? Cric them, MPA them, endo-ET tube them. Allow this conscious patient casualty to assume any position that best protects the airway. It includes sitting up and leaning forward. What the heck?
Well,
Why'd
the
they have
next
to throw
action, I
that
guess, would be to.
Wah, wah, wah.
Never
And they're alert. So they are, let's paint this picture, they're awake, right? They have facial injuries, they're noisy, strong, maxillofacial trauma. What are we gonna do?
Could you go back 2 slides?
Yes, sir.
So
This one?
it says no, I'm sorry.
This one?
There you go. So the casualty in bullet number 4,
Mhm.
rapid breathing in the supine position, that means lying down.
Yes, sir.
So you yourself said maybe have him sit up because he's still awake, right?
Mhm.
Let him sit up and see if he breathes better.
He's probably gargling.
So what do you think the answer is?
4.
4, which is super boring.
Yeah.
Like, not where I wanted. I wanted to cut. They painted that picture, but I think you're right. You're absolutely right. I'll put money on it. 4. It's so boring. The diagnosis is airway obstruction due to his maxillofacial injuries. The principle is to open the airway. Since the casualty is conscious, allow him to assume any position that best protects his airway, to include sitting up and leaning forward.
Steve, as a practical matter, I mean, would you transport that guy just like letting him lean forward, or would you crank him forward?
No, absolutely. If he's conscious and he can manage his own airway, always allow him to do that. Yep. Or you and your friend pin him down and crack him, right? Well, he's probably gonna hold it against you.
Give him some ketamine and
Talks like Michael Jackson for the rest of his life.
I know there's a difference too. Is this an ANA soldier or is this a US soldier? If it's an ANA, I can tell you right now he's getting cracked. That's practice for the medics. That's just how it works.
That's right. That's how you go to prison. That's that Navy SEAL that just got released. It's frowned upon. Okay, airway case study. A Marine platoon is moving across an open field on foot. Dismounted IED detonation, like they didn't know better. There is no effective incoming fire at the moment. It's a self-induced casualty. The face and neck are peppered with shrapnel wounds. The casualty is alert but noted to have labored respirations. A small puncture wound is noted on the left side. Sorry. A small puncture wound is noted on the left side of the neck with minimal bleeding, but there is rapidly expanding swollen area under the skin of the neck immediately adjacent to the midline airway structures. There's a lot of words here. Okay, so let's see what we got. Face and neck have shrapnel wounds. Cat is awake, but they have labored respiration. Small puncture wound on the left side of the neck with minimal bleeding. All right, rapidly expanding swollen area under the skin of the neck immediately adjacent to the midline airway structures. Cool. Dashboard. APU alert and in distress, I imagine. Airway, no blood or obstruction noted. Breathing respiratory rate is 22 and labored, having difficulty there. Radial pulse is strong. O2 sat is 65%. How is this person awake?
Yeah.
Okay, we'll look at this real quick. What do we see? Anything sticking out to anyone?
The subcutaneous emphysema.
Okay, subcutaneous emphysema going on here. What else is pretty notable?
The expanding swollen area.
Yeah.
To be built up with.
Okay, neck. Okay. And labored respirations. Okay, let's see what we're gonna do. Crike the patient using a crike key device, nasopharyngeal airway, endotracheal intubation, or 4, help the casualty into this to sit up and lean forward position. You're not helping us out much here. Cricum, MPAM, endotracheal tubum, help the casualty in the sit-up position and forward. Okay, so let's look at the patient. He's alert. So we're not gonna put an ET tube in him, right? Because he's not gonna like it. Most likely, depending on his occupation, he's gonna have a gag reflex and not tolerate you sticking an ET tube in there, so that's out. Okay, nasopharyngeal airway. He's alert and in distress, he's talking to you. Okay, so I'm not thinking it's necessarily an obstruction like that. Cricum, he's talking to you. He's in distress. No blood or obstruction is noted in the airway. As much as I want to, I'm not so sure about that one. Help the casualty sit up and lean forward. What are we looking at?
Number 4.
Number 4, is that what y'all thinking?
Because it also says the next action you should take. I mean, at some point you may end up having the cracking, but as of right now, so.
Yeah, it kind of sounds similar to my friend Eddie, kind of. You know what I'm saying? Like, with blood's obstructing it. What you got?
I'm wondering whether he would consider putting in a needle if he's got a,
Yeah,
if he's
that's
got
what I
a
was
tension
thinking.
pneumothorax and it's leaking up into his neck.
I'm-
That's what I would do.
I'm with you, but we don't have that option. That's why I was like, they threw a monkey wrench in this one, because I was tracking what you're tracking, which I'm thinking it's probably sub-Q, as someone else said, secondary, high velocity shrapnel, you don't know where it goes. It could have very well punctured. I'm with you all the way, Joe. Well, let's see what we got, yeah? So we're gonna say, what is it, 4? Position, position, position. Right?
Yeah, there you go.
The one time you second guess
That's kind
yourself.
of a weird, for these guys, a weird decision.
That's weird for all of us. I think.
Okay.
Okay, cool. Well, let's read what their explanation is. The diagnosis is airway obstruction due to a rapidly expanding hematoma that has resulted from a shrapnel injury to a large blood vessel in the neck. A nasopharyngeal airway and the sit up and lean forward position will not help in this situation. The best next action is a crike performed with local anesthesia. Okay, next. The setting. A small unit is on patrol in a mountainous area. The unit is ambushed, but hostile fire is quickly suppressed.